just gone through a series of different ECG presentations that you should be aware of. Now let's talk more about the history of differential and management. So we're going to begin by covering the differential diagnosis of chest pain and the description of the pain that makes us think it's cardiac. We're going to then talk about the difference between stable and unstable angina. We'll talk about types of myocardial infarction and non-infarct causes of troponin release. We'll cover management of acute coronary syndrome and management of stable angina. So a lot to get through over the next 45 minutes or so. So let's imagine our patient. I've called them Mr. Chest Pain. So what questions do you ask somebody to assess if this is cardiac chest pain or not? Yeah, Socrates. Everybody knows Socrates. So let's run through Socrates. What questions? What are the most useful questions you're going to ask this patient? Yeah, onset radiation. Chest pain that's ischemic typically comes on over a minute or so. It doesn't come on instantly. It will often be central and it will often radiate. So let's imagine that he's got central chest pain, which radiates to his right arm, and it's been present for 1 hour. What do you think of that? Do you think that's likely to be ischemic chest pain? Yeah, it could be more history required. Yeah, I think that's certainly fair. So what more history are you going to want to ask? So we would want to go through the whole of our Socrates, and we also would want to assess risk factors and past medical history. We obviously also then want to have a look at an ECG, and I'm sure you'll want to have a troponin value. But this is a sort of presentation that could certainly be ischemic. The fact that the pain has been there for an hour is quite helpful because angina pain really, if you have cardiac pain for more than 15 minutes, you expect to have a positive troponin. The fact it's been present for an hour means that if the troponin is negative, that makes it significantly less likely that this is ischemic pain. Nothing is absolute, but it makes it relatively unlikely. So that's quite a helpful feature. We go through Socrates, so that's site. Is it central? So central is a useful feature. If it's on the left side, it's much less likely to be cardiac pain, more likely to be musculoskeletal. The rate of onset, what would we worry about if the pain came on very suddenly? What characteristically causes very sudden onset chest pain radiating to the back? Yeah, aortic dissection. So that would be near instant terrible chest pain, as opposed to pain coming on over a minute or so, which might be very, very terribly severe, but comes on slightly more gradually. Severity is one of those things that it it's very subjective, and patients it can point towards being more likely to be a big infarct than an unstable angina, but it doesn't really help that much, I find, in ruling out an acute coronary syndrome. But certainly you can ask that. Um, Radiation is and character are important. So if it's a heavy or a tearing pain, that's significant. So tearing pain would be aortic dissection. Heavy or tight band would more characteristically be ischemia. If it's sharp, does that help you? What would sharp pain be? So sharp pain takes you more towards pleuritic pain, but just be careful asking about sharp pain because a lot of patients think sharp means severe. So always clarify for them, do you mean it feels like you've got being stabbed with a knife as opposed to it just being a very severe, heavy pain? And they may change what they think about it. It's important not to put words into people's mouths, but it's helpful to clarify and really bear in mind that these descriptions of pain are very much what Caucasian people who are culturally European or Western describe pain as. If English isn't a first language and people with culturally different backgrounds, often the description of pain is much less clear cut. So don't have a higher level of suspicion and don't dismiss something just because it doesn't sound like they've read a textbook. Radiation, so ischemic pain typically radiates to the jaw or to the right or left arm. The left arm is much more common than the right, but it can go to the right. Alleviating factors, so is it brought on with exertion and relieved by rest? Is it affected by food? Is it brought on by lying flat? Lots of different factors might take us towards or away something like gastroesophageal reflux disease. And the timing of the pain, the duration of it, we've talked about how useful that is. If it's less than 15 minutes, it could be, if they're having multiple episodes, that could be unstable angina. Herald symptoms are common. It's not that, it's probably about half of patients who have a herald symptom of chest pain that might be at rest before a few days later having their big infarct. It's relatively common to have some warning you're going to have a big infarct, but sometimes it just comes completely out of the blue. And then what makes it worse? So is it worse with exertion? I'm sure you know all the risk factors. I won't ask you about those, but it's important to remember to ask risk factors and bear in mind family history. It's so common to have a family history of ischemic heart disease that we'd only count it in male relatives less than 55 or female relatives less than 65. So what's our differential diagnosis? We've touched on it now, but does anybody want to give me a differential diagnosis of chest pain? Just pick any differential you like and tell me what symptoms would make you think of that differential diagnosis. So anything you like. Yeah, pneumothorax, pneumonia, good. So what would make you think more likely to be a pneumothorax? So what nature of the pain would take us more? So shortness of breath, you get shortness of breath with both ischemic chest pain and with significant pneumothorax or pneumonia. So sharp pain, yes, and more than that, pleuritic pain, so worse on inspiration. Good. So that would definitely point us towards pneumothorax. Good. Any other differentials? Yeah, pleuritic chest pain and hemoptysis, absolutely. So those would take us towards a pulmonary embolism. Good. So abdominal aortic aneurysm. So how does the pain differ with an abdominal aortic aneurysm? Yeah, so that's that. if it's a aortic dissection, it radiates to the back and would be chest pain. If it's an abdominal aortic aneurysm, it's more likely to be abdominal pain radiating to the back. But they can be confused, and certainly ischemic pain can present as abdominal pain. It's not common, but it's not to be missed to consider ACS in the differential of abdominal pain. Yeah, so if we have gastroesophageal reflux disease, so obviously ulcers don't necessarily cause pain so much as gastroesophageal reflux disease can cause pain. So what's that pain? How would you describe that pain? So it can be exacerbated by certain foods. It can be relieved by eating certain foods. It tends to cause burping. It tends to have specific timing of onset. So lots of factors can differentiate those two. What about esophageal spasm? Does anybody know about esophageal spasm? Ah, excellent. So while you're typing about that, pericarditis, worse lying flat, associated fever, history of recent surgery infection. Yeah, absolutely. So pericarditis is not always worse lying flat, but it's usually positional. It's usually more pleuritic pain, worse with inspiration quite often. Good. So those features would point us towards pericarditis. Great. So the esophageal spasm is an important differential because that's where you get the gastroesophageal reflux disease irritating the esophagus and causing the smooth muscle in the esophagus to go into spasm. So that can cause chest pain, which can be very similar to angina, and it gets relieved with a GTN spray. So that's an important differential to be aware of. Good. I mean, we've gone through quite a lot already. There are inevitably more things. So there are cardiovascular causes with the pericarditis, myocarditis, things like Takotsubo cardiomyopathy. You can, with a hypertrophic cardiomyopathy or cause various dilated cardiomyopathies, you can get chest pains as part of the cardiomyopathy. In a hypertrophic cardiomyopathy, it becomes fairly easy to see why you get it. If you have a very thickened muscle, which is very stiff, it becomes very hard to get blood supply right into the inner bits of the heart muscle. So you get ischemia and you have chronically elevated troponin values. Not all patients with hypertrophic cardiomyopathy, but it's common with it. You can get a similar sort of process with aortic stenosis, and aortic stenosis can lower your threshold to develop angina because you're finding it harder to perfuse the body and the coronary arteries, and the heart's having to work harder. So that can cause an angina. Tachycardias can do it. We've talked about a lot of the respiratory causes already. We haven't covered asthma exacerbation, but obviously that might present more with wheezing. And then there are other things like costochondritis is very important. So what causes, what differentiates costochondritis? So you're looking for ideally a focal area of chest pain. So it happens, you get inflammation of the junction between the sternum and the ribs. So if you press over the joints, you aim for a localized tenderness. Exactly. Thank you, Parveen. So very localized tenderness. If you just get generalized pain when you press on the chest, that's less helpful. You can have a recent viral infection with that, but often it's patients who are stressed, who are taking too deeper breaths in and stretching their chest wall and causing inflammation of the joint through the fact they're stressed and worried about it. And costochondritis is a common thing. So usually if you press over a costochondral junction, there are specific one or two that are tender. And you're asking, does it reproduce the same pain as opposed to just is it painful when you press on? Because if somebody's having an infarct and you go and push on their chest, they'll push you away and say, ow. But you're looking at focal tenderness and you're reproducing the same pain. And then there are loads of other things like herpes zoster. You can have um, nerve root pain, which is transferred around the chest wall. Loads and loads of other comorbidities that can do it. And the history is really useful for differentiating chest pain, but nothing is absolute, and there are always going to be patients that you don't think have got ischemic pain, and it turns out that it is, and that's where troponin becomes so useful. This is a paper from about 20 years ago now that looked at loads of different trials of assessing chest pain, and they found, for example, that radiating to the right arm or the right shoulder is actually more sensitive or more specific for more specific rather than sensitive for ischemic pain. So the high positive likelihood ratio, it's much less common. Can you see it only affected 800 patients of these 29 studies versus diaphoresis or sweating affecting 8,000 patients in 24 in reference 24. So this it's less likely to be going to the right arm, but if it's there, it's actually very much suggests it's ischemic pain. It can obviously go to the left arm or both arms. It's exertional. The presence of sweating, nausea and vomiting, breathlessness, these are important features. So these considerably increase the likelihood of it being ischemic pain. So always ask for those three things. They want sweating, nausea, and breathlessness. Those are very useful features. Described as pressure, you see, actually that we always asking about the character, but how useful is that compared with radiation? You can see very little utility relative to radiation, but it is of value, and always ask it. And you can see that if it's pleuritic, it makes it very unlikely that it would be ischemic. So only 20 both pleuritic pain had ischemic pain. And positional nature of it, sharp, bearing in mind what I just said about sharp, and reproducible with palpitation. You can see how useful these different techniques that we use are. Good. So when we have somebody presenting with chest pain and we've decided that it's ischemic in nature, we have the option to call it stable angina or unstable angina. With that, I would say an acute coronary syndrome. Unstable angina was, I think it used to be a useful diagnosis. The problem is now troponin has basically turned every case of unstable angina into an NSTEMI because it's so sensitive. But it's a useful way of thinking about it. So these are unstable coronary syndromes, acute coronary syndromes, or alternatively, you could have stable angina symptoms. So what is it about the history that tells you that it's one thing or the other thing? So how do you differentiate between a stable angina that you can manage as an outpatient versus an unstable angina for whom you need to call an ambulance? Bearing in mind that you're seeing the patient in general practice or somewhere outside of hospital and you need to decide about admission. So stable angina is reproducible on exertion. It resolves with rest and GTN. Very good, very good. So it's exertional. Anything else to say about it? So it's got to be chronic to be stable angina. If you've got new onset angina, even if it's exertional, it's unstable by definition because the way coronary artery stenoses progress is for the plaque to rupture and then to heal over and become more narrowed. And if it's suddenly become more narrowed, that means that there is an unstable plaque that hasn't re-endothelialized yet. So any new onset angina is automatically unstable angina, even if it's not happening at rest. And so a new onset angina is a very different situation from somebody who's had chronic angina. There is no absolute definition for what chronic versus acute new onset angina is. So I can't tell you that angina that's been there for a month is chronic, or the angina that's been there for a week is chronic. If it's been there a year, I'd be confident telling you it was chronic. I would tend to say if it's been there for over a month, I would be starting to call it chronic, because that's enough time that you'd be expecting the high risk plaque to be improving, but it's certainly going to be higher risk for a longer period than that. So the how acutely the symptoms have come on is very important. Is it new? Stable angina is unchanging. If you had stable angina for years, and then suddenly, rather than walking a mile or rushing uphill brings it on, you're getting it walking slowly on the flat. That's new change. That's unstable angina, because again, the coronary arteries have changed. Now, that could have changed because somebody stopped their antianginals, because they became anemic, or it could be that they've had a big meal, or it was a windy day. There are loads and loads of different factors to bear in mind that will exacerbate the stable angina with it remaining stable. But just tease that out in deciding if something has changed. And stable angina should last less than 15 minutes. Angina shouldn't last for longer than that. Nothing is absolute, but it would be unusual for it to be angina. And bear in mind that a large proportion of people who have angina on their diagnosis list from their GP from years ago may never have had angina in the first place, and it just got labeled as that years ago and has been ever since. So if they haven't had the angina for 10 years, and now they've been getting the same symptoms back, then unless they had it fixed at the time, this could be something else entirely. Unstable angina is new onset, change in severity, occurring at rest. Shouldn't be stable angina in most people. Some people have got very severe coronary artery disease, and although it's stable, they still get the chest pain at rest. But that's pretty unusual, and those are people that we can't fix the underlying problem. So unstable angina at rest lasting longer than 15 minutes. And so if you've got somebody in the community, if they're currently in pain, or if they've had pain in the last 12 hours and have an abnormal ECG, those are the patients that you need to admit with unstable angina. If they've had pain more than 12 hours ago, then and their ECG is normal, then they can go to the rapid access chest pain clinic, and we'll see them within hopefully a few days, but certainly 2 weeks, in order to assess is it or isn't it angina. Now, these are not absolute rules. If you think the patient needs admitting, you've got to be safe. But the practice recommendations are that current pain in the last 12 hours, or abnormal ECG are the criteria for admission. As I was saying, plaques tend to progress with rupture of the plaque. And you can see this is a very diseased coronary artery. And you can see over here, these are plaques, and these are foam cells and free cholesterol lipids in this plaque. And over on this other side, can you see that there's a plaque here? And this fibrous cap has broken, and blood clot has formed. This is a blood clot. And then it's re-endothelialized. And then this further endothelialization of that plaque has also ruptured. And you then had the occlusive thrombus that has done for the patient. And this is the way plaques progress. And if you have an unstable lesion and this clot that's forming and partially occluding or completely occluding the artery, it's very unlikely that little bits of that wouldn't go downstream and cause distal blockages that would cause some sort of troponin release in some of the small arterioles further down the artery bed. So unstable angina almost always causes a troponin release nowadays, that we've got very sensitive tests for it. You'll be glad to know that there are lots of definitions of myocardial infarction, and we're currently working with the fourth universal definition of myocardial infarction. I'm sure it made your day to hear that. It may interest you to know that we've been defining infarct repeatedly over many, many years. And the definitions have changed as troponins have come along, and then high sensitivity activity troponins have come along, and we've got very, very good at diagnosing and defining even the smallest little bit of coronary artery damage, of cardiac damage due to coronary artery disease. Um, I don't want to go over these in detail because I'm sure you don't want me to. But let's talk about the types of MI that all these definitions have led us to have. Now, if your cardiac troponin is elevated, and we say over 99th percentile upper limit of normal is an elevated troponin, and ideally we want to have a rise and a fall so that we can see that it's not chronically elevated. We then look to see, do we have acute ischemia? And if there's acute ischemia and with troponin rise, that means acute infarction. It can either be due to plaque rupture, as we've just described, and we call that a type 1 MI. That's where we have a plaque rupture, poor blood supply, an infarct. Or it could be that we have an increased demand placed on the heart. And although the stenosis hasn't changed, so the chronically narrowed artery hasn't changed, the higher demand on the heart is too much for supply. And so we end up with damage to the heart happening because supply can't keep pace with demand. We call that a type 2 myocardial infarction. And so if you have a severe hypertension, the heart muscles having to work harder to raise the blood pressure, it's harder to perfuse that stiffened heart. So we can get damage due to that. That's, I would say, a relatively uncommon example that's been given by this document. A sustained tachyarrhythmia is more of an issue. So fast atrial fibrillation occurring for a while in somebody with a coronary artery stenosis, that will very commonly cause a troponin release. It may do it with or without, major ischemia just through workload on the heart. But if they're tachycardic and have an ischemic ECG because of a narrowing, that's like getting a patient with a coronary artery stenosis to exercise for a prolonged period of time and can cause a troponin release. And also, if you have major surgery and that's placing extra demands on the heart, or you're very sick with a severe pneumonia, all these things will cause a type 2 myocardial infarction. If the troponin goes up and down without ischemia, so without any evidence of ischemia, we would say that that was an acute myocardial injury, for example, due to strain on the heart with acute heart failure. So if there's ischemia, then we'd be calling it a type 2 myocardial infarction. If there's ischemia on the ECG, if there's no evidence of ischemia on the ECG, we'd be calling it more strain on the heart. So myocarditis would also be a cause of that, where it's not a problem with the blood supply, it's the direct damage to the heart. And if the troponin level's stable, it could be that there's a chronic pathology going on, like hypertrophic cardiomyopathy, or it could be that they've got chronic kidney disease, for example, and that would mean that we weren't dealing with an acute coronary syndrome. I'll talk a little bit more about type 1 and type 2 in a second, just to really clear that point up if anybody hasn't followed that. But there are lots of non-ischemic causes of troponin release. So can anybody tell me some of the non-ischemic, non-cardiac causes of troponin release that I haven't covered already? Rather than non-cardiac, I would think non-ischemic is the better term. So I've mentioned some of them already, but just to name a few more if you know of them. Yeah, anemia, absolutely. So if you have increased cardiac output because of anemia, that can cause troponin release because the heart's under so much strain. It has to be quite significant anemia. Well, in the interests of time, let me put you out my slide of them. So you can have demand ischemia, which is where anemia falls, and we've talked about arrhythmias as well. We've Hypotension will mean that you get decreased coronary artery perfusion. So if a patient is profoundly hypotensive because of shock or because of they might be very dehydrated, for example, that can cause ischemic and troponin release. If they have direct myocardial damage, this is where the non-cardiac I probably need to change, then that direct cardiac damage, trauma to the heart, or if you're in a car accident, you can crash into the steering wheel, and that can cause things like aortic dissection, but it can also cause bruising of the heart, cardiac contusion, and cause troponin release. There are obviously infiltrative disorders like cardiac amyloidosis, chemotherapy drugs, myocarditis. Lots of things can cause direct myocardial damage. And then strain on the heart. We've talked about heart failure, pulmonary embolism would be another one. Loads of possibilities here in terms of acute illnesses with severe infection. So troponin can be elevated with any severe illness, and it's a serious predictor of mortality in patients doing badly, but it shouldn't be treated as an acute coronary syndrome. It should be the underlying condition should be treated aggressively rather than say that they need to have coronary angiography, for example. And then renal failure and intracranial pathologies can do it. We talked about type 1 myocardial infarction just to show you with a diagram. So imagine you have our plaque. Imagine the plaque ruptures and you get clot forming on it, and the clot blocks the artery. This will cause restriction of blood flow, and it will cause an infarct in the affected territory. And you need to see ECG and troponin going with that. And we talked about how if you have unstable angina and unstable plaque, it's a bit like a tree. Imagine that the cross-sectional area of the artery, the start of the artery, is always less than the cross-sectional area of all the arterioles coming from that, branch arteries coming from that artery. So if you have partial occlusion here and bits break off, they'll eventually get to a small enough arteriole to block it, and then that will limit the blood supply to that bit of the heart and cause a troponin release. So unstable angina is possible with a negative troponin, but it's relatively uncommon. Myocardial infarction type 2, this is where imagine you've got a severe stenosis, and that is limiting flow at rest and stopping them from exerting themselves because they get chest pain, and then you make somebody profoundly anemic, and suddenly the patient can't get enough blood flow through that artery to perfuse their coronary artery, and that causes infarct and damage. So a myocardial infarction type 2 involves infarct and damage to the heart muscle, but it's because of an imbalance between perfusion and oxygenation. And there are various things. Vasospasm can also do that. And again, you need the ECG evidence that they're having evidence of infarction with that to call it a type 2 myocardial infarction. These are high-risk patients, so treat the underlying cause of the type 2 myocardial infarction effectively, treat their sepsis effectively, and otherwise their cardiac condition can be managed as stable angina. There are lots of different troponin tests available. The one we use, we do our high sensitivity troponin. We look out for dynamic ECG changes while we're waiting for it. If it's less than 5 and the sample was taken over 2 hours after the onset of pain, then we can rule out an STEMI. If not, then we can look, is it over 100? If it's over 100, that's our threshold for it being an NSTEMI. If not, we repeat it after 2 hours. This pathway ought to be available on the boards and on CDU for you to follow. But basically, we're looking to see, is the value below or above 100, and does it change? And it's a very, very good rule out, but not an absolute rule out. As I showed on this slide, the negative predictive value approaches 100%, but it is not quite 100% sensitivity for detecting a myocardial infarction. So this leaves you with about a 1% chance you've got unstable angina and a negative troponin. How do you treat an NSTEMI? Well, we give aspirin and a loading dose followed by a regular 75. We talked last time about prasugrel for STEMIs. For NSTEMIs, we give ticagrelor for most patients. So it's 180 milligram loading, then 90 milligrams twice a day. We give 48 hours of clexane, 1 milligram per kilogram twice a day. Statin, very, very important, and we give 80 milligrams of atorvastatin, but they're very frail elderly patients or patients with liver damage. There is an increased risk of rhabdomyolysis with a big dose of atorvastatin. So do just bear in mind that the 80 is for most patients, not for all patients. Bisoprolol and ramipril, the evidence base is not quite so strong, but trials have tended to have patients on ACE and beta blockers. So think about starting those, and certainly control of blood pressure is important. All patients coming in with an NSTEMI need to have their lipid profile, their HbA1c for diabetes, and thyroid function checked. If it's been done in the last few months, then that doesn't need to be repeated, but if not, it needs repeating. And if they've got an NSTEMI, we should think about proceeding to coronary intervention. Not all patients, some people, the risks of proceeding are going to be greater than the benefits. So that needs careful consideration with our frail patients. We certainly wouldn't want to deny anybody a treatment that could be very beneficial to them, but we don't want to put patients through procedures where it isn't a benefit to them. And also, it's very important to address lifestyle measures and cardiac rehabilitation. We've talked about STEMIs a couple of weeks ago. We've talked about prasugrel before. So if they are over 75, less than 60 kilos, or have had a previous stroke or TIA, we give ticagrelor. Otherwise, for a STEMI, we give prasugrel. Anticoagulation comes up a lot. And this does need individualized treatment, and especially for a metallic valve, that really does complicate things. And we would tend to try and do a procedure on anticoagulation. So you should be presuming that the warfarin will be continued. Sorry, I'm being disturbed. Oh, thank you. If patients are on a DOAG, that may be paused, it may be continued. It will depend upon the doctor doing the procedure. So it's worth flagging that up to the cath lab to see what they want to do. And following the cath, the person doing the procedure should give the advice about what you need to do. Commonly, it will be 1 month of triple therapy, then the following rest of that year, clopidogrel and the anticoagulation, and then after that, just the anticoagulation. But it will depend upon what the interventionist says. There are all sorts of papers, and there are so many saying slightly different things. It's hard to know exactly the right pathway to choose is, and that falls to the interventionist because it's their complication if something goes wrong post-procedure. Hyperglycemia. This is one of those frustrating areas. This document is actually 11 years old, and it was only a couple of years ago incorporated into NICE guidelines. And there's absolutely no doubt that there is a strong association with mortality and elevated blood glucose. The question is it a risk marker that tells you that somebody's at risk, but there's nothing you can do about it? Or rather, addressing that marker won't do anything about it. So, for example, being male is going to increase your risk of having an infarct. There's not a lot you can do about being male, although I suppose there are things you can do about it. But whether that reduces your risk, I don't think the studies have been done. The other alternative thing is the risk factor, and risk factors like hypercholesterolemia you can do something about. You can modify. The aim is to get blood glucose below 11, and you may want to use a sliding scale insulin for that. If it's 11.1, you might want to just see how it goes. If it's 20, you'll want to consider sliding scale insulin, so you need to use your judgment. But the bottom line is that this papers full of saying that the evidence base for what we do is very, very poor, and to get the diabetes team to advise about treatment post the acute phase, so insulin or oral agents. The important thing is to control blood sugar. And I just thought I'd share with you that there are various studies, and the assessment by NICE is that there are serious issues with virtually every aspect of all of these papers. So the quality of the evidence for what we do in diabetes is very low. It's an area rich for further research. We do coronary angiography. Typically, we go through the radial artery. We only go through the femoral artery as a last resort because of the risk of retroperitoneal bleeding that we discussed last time. We use various shaped tubes to access the different arteries. This is an example of a fairly nice looking left coronary artery, looks normal. This, on the other hand, is a diseased right coronary artery. Can you see how there's a narrowing here? And this looks like a slit. This is maybe like an apple core where you eat out equally from each side. Here, this is also a narrowing, but this is almost the same lumen as the rest of the artery. And this haziness, this faintness, is because there's less depth of contrast, because only this bit have got contrast in as opposed to the whole artery. And so we like to look in two 90-degree or orthogonal planes so that we can see eccentric plaques, which are just as significant as concentric plaques. And working out if it's actually causing flow limitation just by looking at it is very hard, because it doesn't tell you exactly what the artery looks like just looking at it. And the length of the lesion, as well as how tight it is, has a big impact on how actually significant for the flow of blood it is. We've talked about stable angina. If you have stable angina, then we know from a series of large studies, and particularly the ischemia trial, which had in 80% of their 5,200 patients had more than one artery that was severely stenosed. They spent $100 million on this trial, and they found that there was no benefit to doing coronary angiography and stenting versus just conservatively managing the patients with good statin, blood pressure control, lifestyle, etc. So if you have stable coronary artery disease, nobody can say to the patient or to you that your patient should have a stent put in to make them live longer or reduce their risk of having an infarction, because there's a lot of evidence that that doesn't help, with the exception of left main stem disease. So stable coronary artery disease can be managed conservatively with medications. Medications are very important, and whether you intervene on the coronary arteries or not, the medications are very important to reduce risk of infarct. STEMI, on the other hand, it's incredibly valuable to unblock the arteries. So in a STEMI, it's very valuable to do stenting, but in stable coronary artery disease, it isn't. It isn't at all beneficial. It can help symptoms, absolutely, but it's symptomatic treatment, not a prognostic treatment. Interestingly, for an NSTEMI, treating an NSTEMI in hospital with PCI reduces risk of a further infarct. It doesn't reduce mortality. So what do we do in treatment of ischemic heart disease? Well, in all patients, we should be giving prognostic treatments, whether it's unstable or stable. And our prognostic treatments are things like statins and aspirin, blood pressure control, we've said with an ACE inhibitor and beta blocker, and then lifestyle advice and diet and exercise. These are very, very important. Anti-anginals are symptomatic treatments. So I get GPs worried about adjusting isosorbide mononitrate. It's a symptomatic treatment. It's not going to prognostically affect the patient one way or the other. Now, if you stop their isosorbide mononitrate and they promptly end up in hospital with chest pains because their angina has changed in nature, that's obviously an unfortunate thing, but that's not that's not an unstable angina. That's somebody failing to recognize that all they need to do is have their isosorbide mononitrate restarted. But that falls under symptomatic treatments. Anti-anginals are symptomatic treatments. Samson is a trial which everyone, I think, should be aware of. Beautiful, beautiful little study, the kind of thing I wish I had done because it was so easy and so valuable. So they found 60 patients who were intolerant of statins. And for 4 months, they gave them atorvastatin. For 4 months, they gave them a placebo. And for 4 months, they gave them no tablets at all. And the patients didn't know which 4 month period they were on because they had, well, they knew then they weren't on tablets, but they didn't know obviously if they were on placebo or atorvastatin. It was double blinded. And so they were asked their symptoms throughout this year-long period. And symptoms were there when they weren't on tablets. You didn't get no musculoskeletal chest pain because you were just on no statin or placebo. But the fascinating thing is symptoms were much worse both on the placebo and on the statin, bearing in mind these were patients that were intolerant before of their statin. So you can see that they're expecting things to be worse, and therefore they are worse. The vast majority of side effects of statins are patients expecting problems or getting problems and blaming them on their pills. And 50% of these patients successfully were restarted on their statins. So something to tell patients about who tell you they get musculoskeletal chest pain with atorvastatin. Please be respectful about it. Don't disregard their concerns. But the Samson trial tells us that a lot of the concerns are not because of the statin. And then for symptomatic treatment, there are lots and lots of options for angina. We could give a beta blocker, which would be first line, or if we don't want to give a beta blocker, a calcium channel blocker like diltiazem. If they're tachycardic, that would be the same choice. If they're bradycardic, we wouldn't want to give a beta blocker, so we could give a dihydropyridine calcium channel blocker like amlodipine or felodipine. If they've got heart failure, beta blocker would be a good first choice, but start low and go slow. Don't give them too much beta blocker too fast. If their blood pressure's low, you could give them a low dose of similar medications. So you just go in more gently. As a second line, you could add something like amlodipine to a beta blocker, or if their heart rate's still fast, you could add diltiazem to a beta blocker, but that could cause heart block, so just bear in mind, be careful. If their heart rate's low, you could give a long-acting nitrate like isosorbate mononitrate. They often cause headaches, but they're otherwise really excellent drugs for angina. Again, if they've got LV impairment, you could give a long-acting nitrate or ivabradine. Ivabradine's a medication that slows the heart down. And just be careful because long-acting nitrates, isosorbate mononitrate, are very vasodilating, so they can cause postural hypotension, particularly in elderly patients. And then third line, you can see, I won't go through all of this, but one drug I find very useful is ranolazine. I'm not a big fan of nicorandil, but ranolazine is a very good drug for not having any impact on blood pressure. And it can be really useful in patients who are hypotensive or bradycardic. But go through the basic things first. Try beta blocker and diltiazem and isosorbate mononitrate. Brilliant. Well, thank you very much for listening. I hope that's been a helpful run through of angina and acute coronary syndrome. Obviously, it's very important to tease out the difference between stable and unstable angina and bear in mind that maybe it's become unstable because the patient's become anemic, which doesn't mean you need to treat the angina so much as treat the anemia. Troponin's a really good rule out. It's not such a good rule in. There are lots and lots of other possible causes of a raised troponin. ECG's critically important because it will tell you emergency patients, emergency treatment is required, but it's normal in 50% of patients with acute coronary syndrome. And then remember about how to reduce risk with medications and lifestyle for stable and unstable angina. That is really, really important. Don't get so excited that we've stented the patient that they don't take their antiplatelet drugs afterwards, for example. And rapid access chest pain clinic can be a good way of getting urgent review of a patient you're worried about. Thank you very much for listening. Any questions at all?